Hello, my name is Preeti Raghavan, and I'm the Director of the Center of Excellence for Treatment, Recovery, and Rehabilitation at the Sheikh Khalifa Stroke Institute at Johns Hopkins University. Thank you for joining me today. My talk is on a unified model for stroke, recovery, and rehabilitation. The talk is organized into 4 modules. First, I will talk about the current model of stroke care and why we need a new model. Second, I'll talk about the role of the Sheikh Khalifa Stroke Institute in creating this model and its integration with the ICF model in module 3. And then finally, on the implementation of the unified model of stroke care. So the goal for the new model for recovery and rehabilitation is to define and coordinate an intensive strategic effort to treat stroke early and promote recovery in order to restore function and quality of life to those afflicted. We would like to develop effective stroke systems of care across the continuum. Now you might ask, why do we need it? Don't we have a good enough system? I would argue, as many have, that our system is broken. Winstein et al. In 2016 wrote about acute stroke care guidelines. And following on those footsteps, they summarized very, very nicely the current state of rehabilitation in the United States. Essentially, patients move from one silo to another, and then they go home and they may never get the rehabilitation they need. In fact, it has been shown that only 30% of individuals who need rehabilitation actually get it. And sometimes they get it for a very short period of time, and oftentimes their recovery is incomplete. The focus of the movement across these silos is really triage and transition of care, not recovery. So the challenges of the current model are lack of access to care centered on recovery, lack of core measures meaningful to recovery that can track it, lack of continuity of care across these various levels, and lack of a unified model for the delivery of care focusing on recovery. So you might ask, what is recovery? Now, recovery could be defined for movement, for cognition, for language abilities. In this talk, I'm going to focus primarily on movement. And I'm going to argue that restoration of movement also requires some degree of restoration of cognitive and perceptual processes. So recovery has been defined by Levine et al. As the ability to perform a movement in the same manner as it was performed before the injury. So that's behavioral recovery. And what behavioral recovery requires is that sensory input informs appropriate motor output, which is behavior, right? And the sensory input is tactile, proprioceptive, and by definition, it requires cognitive perceptual processes like attention. But behavioral recovery requires 3 things. It requires neural restoration. For example, for motor recovery, that means muscle activation. So the signal has to be sent to the muscle so that it can contract. But that's not all. In order for sensory motor integration to occur, there has to be peripheral restoration. In other words, the correct sensory inputs that modulate muscle activity need to get through. And I'd like to remind you from the previous slide that peripheral restoration requires both inputs from the skin as well as inputs from the muscles themselves. And then there is cardiovascular restoration, or the need for adequate blood supply to meet central and peripheral demands. One of the major barriers to behavioral recovery is immobility. The dictum "use it or lose it" definitely holds true here, as in every other condition that leads to immobility. Immobility has wide-ranging effects on multiple systems, but I think relevant to our discussion today, it affects the musculoskeletal system, causing loss of muscle mass and weakness, osteoporosis and contractures. But in the case of stroke-related immobility, the paresis exacerbates all of this anyway. There's already underlying paresis. And on top of that, the immobility adds to the already existing weakness. The immobility also contributes to further functional deficits, behavioral changes, sleep dysfunction, and also leads to circulatory problems like increased edema, which can reduce, as I mentioned previously, the peripheral inputs. So immobility plus paresis leads to massive changes in muscles that I won't detail over here, but they've been described in a paper by Stecco et al. From 2014. And we've argued there that the changes in muscles are not just weakness, but also other changes that make the muscles stiff. They produce active muscle stiffness. They exacerbate neurally mediated reflex stiffness or spasticity, and can lead to passive muscle stiffness or contractures, which really increase the disability and decrease the activities of daily living. So at this point, I think I've tried to make a case that the neural damage in conjunction with immobility from not giving adequate amounts of rehabilitation because the patients are moving across the levels of care, can really create havoc on recovery. However, the good news is that high-dose therapy can lead to improvements, can lead to recovery, even in the chronic stage, right? So this was a really exciting paper that came out fairly recently by Janice Daly's group. And what's most exciting about this study is that they were able to provide up to 300 hours of rehabilitation in the chronic stage. And what they showed was that even though these patients, they were moderately severely affected patients, and despite that, by giving them high intensity therapy over 150 hours, they saw dramatic improvements in the Fugl-Meyer scale, which is a standard scale of motor impairment after stroke. And the degree of improvement exceeded the minimum clinically important difference. But they ask the question, if after 150 hours, patients reach a plateau, or if they can improve further by continuing to give another 150 hours. And what this graph shows is that if you give them another 150 hours, they show an equal or greater amount of improvement. This is quite dramatic. And the changes in impairment correlated with changes in function as well. And they persisted to a great extent on follow-up. So to summarize the current gaps, what I've been trying to show is that the current model is not particularly effective because the focus of rehabilitation services is on triage and transitions of care rather than on recovery. Recovery requires neural restoration, which is dependent on peripheral input and blood flow, which requires movement. And these are compromised due to disuse, which is rather rampant even in rehabilitation units, as has been shown in the literature. But even in the chronic stage, if patients are provided with high-dose therapy, recovery can occur. So this begs the question, well, what if we could provide high-dose therapy early on in the course of rehabilitation? The mission of the Sheikh Khalifa Stroke Institute is to see if we can promote the early recovery that we've just talked about. So our formal mission is stroke diagnosis and treatment that is informed by the latest scientific research and discovery. And our vision is to improve the life of every stroke patient. To do so, we plan to develop the premier stroke recovery program that combines innovative clinical care, technology, and research. What is premier stroke recovery? Premier stroke recovery consists of the 4 Ps. It's predictive in that it can identify not just recoverers versus non-recoverers, but different types of recoverers that might benefit from different kinds of treatment. It's preventive in that one can provide early rehabilitation and perhaps ameliorate some of the long-term disability that we see these days. It's personalized in that we can use metrics to precisely tailor the rehabilitation interventions to the individual's unique profile. And it's participatory in that its rehabilitation is not a pill. It engages patients to participate in their own recovery throughout the continuum. As Buckminster Fuller put it, you can never change things by fighting the existing reality, no matter how bleak. To really change something, we've got to build a new model that makes the existing model obsolete. I think this quote is very pertinent today, especially in the time of COVID-19, where we're just having to build new models anyway, because there is no other option. So one of the major tenets of this new model is to provide early and frequent rehabilitation to promote functional recovery. And we have multiple programs to do that. You might be familiar with them separately, but one of the well-established programs is the Activity and Mobility Promotion Program called AMP, which promotes early mobilization by nursing staff. So any patient anywhere in the hospital needs to move more to prevent the complications of immobility. Another program that we have at Hopkins is the ARISE model. ARISE stands for Acute Rehabilitation Intensive Services. This is where we provide hyperacute interdisciplinary rehabilitation. That is, we're providing up to 3 hours of physical, occupational, and speech therapy in the acute care units, for example, in the stroke unit. It requires a great deal of care coordination, but it is possible, and it can go a long way towards enhancing functional recovery early on. From the stroke unit, the patients may go into the inpatient rehabilitation facility, which provides acute interdisciplinary rehabilitation, as in many other centers around the world. And then there's the outpatient rehabilitation, which is subacute interdisciplinary rehabilitation. So one of our goals is to synergize the outcome assessments, the technology implementation, the education and training across these levels. That is, very early on when patients are in the hospital, when they're in the stroke unit, when they're in acute inpatient rehabilitation, all the way to their outpatient course. So the Stroke Institute's model of care for recovery and rehabilitation involves integration of care across levels, building an outcomes database to measure care at all of these levels. And ideally, these would be outcomes that can be used at these various points of care. We want to use these outcomes to also develop algorithms for precision rehabilitation so that patients could get the right treatment at the right intensity at the right time. And then we would like to demonstrate the effectiveness of this model and disseminate it through the learning network. Module 3 is about integration of the SKSI model with the ICF model. You must be familiar with the ICF. It stands for International Classification of Functioning, Disability and Health. And this was developed by the World Health Organization as an international standard to describe and measure health and disability. The key idea of the ICF is that health is really about participation in one's societal roles. But in order for somebody with a health condition to be able to return to their societal roles, they may need treatment, which may occur at the level of impairment. That means at the body function and structure level. For example, treating weakness would be treating an impairment. But it's not enough to just treat the impairment. You've got to also treat the functional limitations. You've got to, the reduction of impairment is not enough. It's got to lead to changes in functional ability. And those changes in functional ability are not enough either. They've got to restore social participation. But clearly, impairments, functional limitations, and societal restrictions cannot be treated with one silver bullet across all individuals. It's very important to take into consideration contextual factors like the individual's environment and personal factors that inform how patients may respond to the treatments across these levels. Now, the WHO model, the ICF model, has been out there for quite a long time now. But in terms of implementing this model in stroke rehabilitation, I would argue that we are still pretty far off. And that's because the model itself is extremely comprehensive, but its implementation is complicated because it actually bridges 3 separate models of care. So, in order to reduce impairment, one needs to facilitate biological recovery and normalize physiology, right? And that requires the medical model. So you've got to treat the electrolyte imbalance, you've got to treat the weakness, you've got to treat the spasticity. That's impairment-based treatment or impairment-based training in rehabilitation. But to actually now translate the changes in impairment to function, you need an educational model because the person has to relearn how to do their daily activities again. And clearly, we have all seen that if we teach a patient improper strategies early on, while we are trying to reduce impairment, those abnormal strategies of movement stick and they're extremely hard to unlearn. So learning the right strategies is very important from the get-go. So that when an individual is able to get back to function, they use the right strategies and they're not using compensatory strategies that might actually set them back over the long term. And finally, in order to truly translate function to social participation, we have to teach the patients to manage themselves because rehabilitation is a long-term proposition and the patient has to be interested, has to take charge, and we have to teach them how to do that. It is not a given, and we cannot blame it on the patient's motivation or social support structure. We actually have to teach them how they can manage themselves and become more self-efficacious. And I think I'm going to argue in the next few slides that every patient needs impairment-based training, functional retraining, and self-efficacy training, no matter where they are in the system, whether they're in acute care, whether they're in the inpatient rehabilitation unit or an outpatient. We need to make sure that patients are getting all 3 types of training. And you might ask why. Well, I'll try to explain. So first of all, as we've talked about before, recovery doesn't come from a silver bullet. There isn't a magic pill. there are many individual factors to consider. For example, acuity. Early treatment can capitalize on the critical window for recovery. So an acute patient should and can be treated as aggressively as possible as they can tolerate. Uh, I don't mean, give them intense therapy while their stroke is in evolution or when they are not physiologically ready. But I mean, the literature has shown that giving early and frequent rehabilitation can ameliorate the ill effects of immobility and capitalize on the critical window when there are numerous growth factors um, present to potentiate plasticity. Second, recovery processes are different for individuals with different degrees of severity. Patients who are more severely affected may take longer to be ready for aggressive therapy, and their time course of recovery may be longer. But they require a great deal more attention than perhaps the patients who are less severe. In our current system, I'm going to argue that severity is often an excuse to not give sufficient therapy, because there's been this assumption that people who are very severe don't recover. But as Janice Daly's research just showed so elegantly, even people who are very severely affected in the chronic stages can recover. So I think that begs us to reconsider how we take into account a patient's severity. And finally, personal factors, the social and emotional factors, or the contextual factors, determine both individual and societal resources for recovery. And that is also something that must be considered in providing precision rehabilitation. So basically, there are potentially many buckets of treatment depending on the degree of acuity, depending on the degree of severity, and depending on various personal factors. And as I mentioned previously, each patient requires all three types of training: impairment-focused, function-focused, and participation-focused. And one might think that the more acute and more severe patients should get impairment-focused training, and as they become subacute and their impairment reduces, they can get function-focused or participation-focused training. But if we incorporate the ICF model into every level of care, basically we need to provide all three kinds of training for every single bucket, for patients in every single bucket. And I'll give you an example. So, for example, let's say a patient is weak and has low endurance. You might say, well, if we give them impairment-focused training alone, then basically they are not going to participate in gait training at all until they regain sufficient amount of strength in specific muscle groups to initiate gait training. But that means that you deny them the opportunity to coordinate the muscle groups for in a functional manner. Similarly, if patients don't see the value early on of walking to participate, let's say, in a group meal event, uh, then they won't be ready to go home and resume their societal roles as, a functioning member of the family that goes to the dining room to eat with the rest of the family. So it's important to focus on the impairment, the function, and participation at all three levels. Module 4 is about the implementation of the unified SKSI model of stroke care. So in order to implement this model, integration has to occur across operations, outcome assessments, technology, and education. In operations, we've got to integrate the programming across the continuum. So starting from the stroke unit to inpatient rehabilitation to outpatient. The core outcome measures that we are selecting need to be administered uniformly, no matter what the setting, across time. We want to use technology to enhance access to care, and to incorporate the principles of precision medicine, gaming, as well as tele-rehabilitation. And finally, education, to create a learning network to disseminate the ideas that we have learned, to implement this unified model of care delivery. So the big differences between standard of care and the SKSI model are that on the stroke unit, PM&R consults, physical medicine rehabilitation consults, are typically conducted within about 24 hours to triage patients to determine where they're going to go next, whether to subacute, home, or to inpatient rehabilitation. And typically, patients may get 1 to 3 sessions of therapy per admission, maybe 1 session of physical therapy, 1 session of occupational therapy, and 1 session of speech therapy. At the most, they may get a stroke binder for education. At the SKSI, we implement our outcomes within a couple of days of admission. We implement the AMP and ARISE programs to mitigate the effects of immobility. And the ARISE program gives patients up to 2 sessions of PT, OT, and SLP daily in collaboration with nursing and therapy. Because we've already taken the outcome measures, we can triage patients into levels to implement the precision algorithm, depending on their degree of impairment. And the idea is to start to engage patients in functional activities as early as possible, but keeping in mind not to reinforce compensatory strategies. And finally, since 50% of the patients who are admitted to the stroke unit might actually go home, it's important to involve patients and caregivers in education to promote self-efficacy upon discharge, so that the patients are empowered to take charge of their own therapy. Once patients are transferred to inpatient rehabilitation, again, the standard of care is quite different from the SKSI model. The standard of care is to focus on compensatory strategies, regardless of the impairment. So really the idea is often to get the patient home as soon as possible. So you're taking higher level patients, you're teaching them to perform their ADLs, to move around, but without much regard to changes in impairment. And it's often considered okay to teach them compensatory strategies. Patients in the United States get 3 hours of therapy per day, and that is the minimum required. and 1 family meeting is required per admission. But at the SKSI, just like on the acute stroke unit, we assess impairment, function, and participation right away. And the goal is to optimize training time to the maximum. So really the idea is that to the extent possible, we want patients to be engaged while on the unit. So we try to create an enriched environment. We implement the precision algorithm so that the right type of training is provided to the right patient. And again, it's important to enhance patient participation in functional activities, but making sure that they're not just using compensatory strategies, but learning how to do the movements correctly. And finally, it's important to engage and empower patients and caregivers to participate in their own care, in self-management, and to enhance their self-efficacy. Once patients are discharged, again, the outpatient programs are catered to the patient's individual level of disability. So high frequency programs, maybe 5 days a week for an entire day, moderate frequency programs 3 days a week, low frequency programs 1 day a week. And a patient may move from a high frequency program to a moderate frequency program to a low frequency program, and then finally to a maintenance or wellness program. And the idea, again, is that we address all 3 models of care: the impairment-based training, the medical model, the functional retraining, the educational model, and participation training by enhancing self-management and self-efficacy. So this is quite different from the standard of care, where patients might get just a nominal frequency of 2 to 3 days per week. And they don't want to be discharged, so we struggle to discharge them, and we also struggle to keep them. The patients that we think need more therapy often don't get enough therapy because of insurance limitations. And we lose the patients. There is often lack of continuity of care. So we do not know how they've ended up or why they've ended up where they have. So one of the key implementation practices is really to focus on the inpatient-outpatient discharge. And we have tried to bridge this gap by implementing a discharge algorithm. And the reason for that is that this is a key transition point between the medical model and the educational or the self-management model. Because what an individual has learned in the hospital doesn't easily translate into a home setting. There's actually some hand-holding required so that the patients are not unsafe, and so that they don't get readmitted or develop complications or inadvertently do things that would lead to poorer recovery. And this discharge algorithm is especially critical as the length of hospital stay shortens and more acute patients, who are perhaps not yet quite ready, are going back into the community. So the discharge algorithm, if implemented correctly, can be a real opportunity for sustained recovery. If not implemented correctly, things can fall apart during this transition. So moving on to building an outcomes database, one of the key ideas behind the framework for outcomes measurement is that we want to be able to measure recovery across the continuum. We must capture all domains They must be repeatable across time. So we are currently trying to follow patients for at least a year and longer, if possible. The outcomes must be sensitive to change. So they should be able to demonstrate progression from impairment reduction to improvement in function and to social participation. Very important is that these outcomes inform triage into the various levels for precision rehabilitation, and they must inform treatment in order to justify the time taken to perform these outcomes. So, and they must be captured in the EMR so that it's not more work. And also, where possible, we are trying to incorporate high content kinematics. So the idea is not to have an exhaustive list of outcomes, but to have a core minimum set, which is part of standard of care. And then there could be additional evaluations, which are nice to have or research focused around this core minimum data set. So these are some of the outcomes that we have selected with great degree of deliberation across the disciplines. And this is our core data set. And the idea, as I mentioned previously, is that we will implement this in the acute care setting, in inpatient rehabilitation, and then in outpatient periodically. Some of these outcomes at the bottom row would be performed by the physicians, so that we could monitor their impairment, the neurological impairment, function very quickly with a Euroqual 5D, and also monitor social participation and self-efficacy. And each of these rows represents measures that will be obtained by the various therapy disciplines. So these outcomes are being used to triage patients to provide precision rehabilitation or the right treatment at the right intensity at the right time. So in the current model of care, really, if you graph the intensity of rehabilitation on the y-axis and the time for rehabilitation on the x-axis, the current model of care represents an inverse pyramid, where the least functional individuals, the ones who are most impaired, actually get the least intensity and time for rehabilitation. We ship them off to subacute facilities or to nursing homes and give up on them, right? Whereas the people who are least impaired, they might continue to get therapy on the acute rehabilitation unit because they're getting ready to go home. And, so it's a lopsided model. The desired model of care, I'm going to argue, is that the least functional individuals need a higher intensity of rehabilitation and a greater time for rehabilitation so that we give them the opportunity to fully recover. Otherwise, we never tap into their true potential for recovery. And in the long run, it's actually more expensive for society because they end up with complications. They take up more resources in the hospital because of them. They may have readmissions. Whereas if we focus on them at the outset, then they can potentially become productive members of society. They can potentially recover, especially given the latest research that I shared with you earlier. The most functional individuals, well, it is not that they need to be denied rehabilitation, but most critical to their recovery is self-efficacy. So if we can teach them to take care of themselves, they are going to be better off, and they're going to recover faster and get back to their societal roles faster. So just to recap, the idea of precision rehabilitation is to provide the right combination of impairment, function, and participation focused treatments for individuals in each of these buckets. And what we have been worrying about is how do we provide the rehabilitation economically, right? Because cost is definitely something to be concerned about. So by triaging patients into risk levels based on their degree of impairment and functional limitation, we can deliver targeted treatment to each of these levels. So in the pyramid that I showed you earlier, level 1 patients should have the mildest degree of impairment, they're generally high functioning, and they are low risk for safety because of their limited physical, cognitive, and psychosocial deficits. So these patients could perform a lot by themselves. During the transition of care, maybe what we need to, during the transition from inpatient to outpatient, maybe what we need to do is focus on telehealth visits and remote monitoring so that we can facilitate education, self-management in their own environment. Patients who are more impaired and who have more functional limitations may actually require more hands-on therapy, but perhaps at a low intensity and frequency because there's a lot that they can do themselves and they understand what they need to do. But close monitoring with telehealth will make sure that they don't fall through the cracks and that they can engage in education and self-management in their own environment. Patients in level 3 may be moderately severely impaired and less independent, and they may be more vulnerable for poor recovery and safety risks. Now, these patients may actually need more hands-on therapy as well as close monitoring, but not as much as the patients in level 4 who are most severely impaired. And they would need a comprehensive plan, like a day program, where they get frequent hands-on therapy several times a week at high intensity and frequency to prevent the adverse effects of not providing such therapy, and then close monitoring with telehealth if they do go home. So the next steps are to demonstrate the feasibility, the efficacy, and the cost effectiveness of this new model of care, and to create a learning network where we share what we've learned and break down the silos of acute care, inpatient and outpatient care, where we really take care of the patient across the continuum, because it's not that we are concerned with only our individual level, we're concerned with the recovery of the patient. And that can only happen when the outpatient therapist knows what happens in acute care and vice versa, so that there's exchange of information, and what happens at one level of care is facilitating what happens at another level of care. And this will help us develop enhanced standards of care for stroke rehabilitation. So I'd like to thank the Sheikh Khalifa Stroke Institute for funding this work, which is a collaboration between the Departments of Neurology and Physical Medicine and Rehabilitation at Johns Hopkins. And none of this work is done by me alone. It's definitely a team effort, and the teams consist of faculty, both in neurology and physical medicine and rehabilitation, as well as therapists and nurses, and a number of allied staff. I hope this has been helpful. And thank you for your attention. Please feel free to reach out to me should you have any questions. Thank you very much.